So about headache, headache is a common problem in childhood, with a majority of cases have tension headache. Okay, headache can be isolated presentation in case of febrile illness, in case of CNS infection, head trauma, even sinus infection or otitis media. However, it's commonly present as recurrent presentation, and this recurrent headache can be less commonly due to secondary causes, due to increased intracranial pressure or due to presence of hypertension. So evaluation for blood pressure elevation or manifestation of increased intracranial pressure manifestations is very important in any case presenting with headache. The more common is the primary headache, okay, which have no organic pathology. These include tension headache, migraine, and cluster headache, with the more common is tension headache. Okay. So for evaluation, if acute severe headache is considered an emergency, you should examine the patient very well for presence of fever, neck rigidity, to exclude signs of meningeal irritation. Maybe this is a case of meningitis or CNS infection. Also, your priority is to exclude presence of lateralization signs or focal neurological signs where you have abnormal neurological manifestations in one part of the body, having abnormality in tone, in power, even in reflexes. You may have exaggerated reflex on one side, or you may have positive Babinski on one side, and so on. So focal neurological signs, this is an emergency which necessitates to search for a cause by neuroimaging. You may find intracranial hemorrhage, stroke, or whatever cause. However, in headache that it is not in an emergency situation, you should take full detailed history to categorize the headache into episodic, recurrent cases that include migraine and tension headache, or chronic progressive headache that is associated with increased intracranial pressure, or chronic and non-progressive cases that is considered the chronic tension headache. So in the history, you should ask about the details of the episode of headache, okay? About the onset, about the course, intensity of the headache. Is it severe? Is it moderate? Is it mild? Also about its duration, okay? Does it persist for just a few hours or maybe all the day, and so on? Ask about the duration. Ask about what relieves the headache and what precipitates the headache. This is very important. Ask specifically about aura symptoms. Aura symptoms suggest migraine headache in the form of visual symptoms, in the form of weakness, nausea, and vomiting. If the patient has certain symptoms that tell him the headache is coming, okay, so this is aura, which suggests migraine headache. Ask about family history, very important, but also migraine headache usually has a family history, especially on the maternal side. Ask about response to analgesia, also very important. Examine. Don't miss to measure the blood pressure to exclude hypertension as a cause. If any suspicion about the intracranial pressure, you should do a fundus examination for optic nerve changes like papilledema, which suggests an increase in the intracranial pressure. Don't miss, very important, the neurological examination, which include the general and local examination for the motor function and the sensory function. We will mention it later, to pick up any abnormal neurological signs that may be focal and suggest a sign of lateralization, suggest an intracranial pathology, organic lesion that caused the headache. So about the primary headaches, okay, tension headache is the most common. Tension is bilateral, okay, tightening or encircling the head characteristic, and it's not pulsating, which suggests migraine. Also, it is mild to moderate, usually not severe, and it's not aggravated by routine physical activity as occur in migraine, and they're not associated with nausea or vomiting, also as associated with migraine and other organic pathology. Usually it is episodic, which can be frequent, occurring more than 1 or 2 days per 15 days, or maybe infrequent, which is less less than 1 day per month. Can be chronic, also tension can be chronic. Usually by examination, post blood pressure, fundus, and the neurological examination all are normal, and no red flag signs that would raise suspicion of intracranial pathology or severe disease. So it is bilateral, it is tightening, non-pulsatile, mild to moderate. It's not aggravated by routine physical activity and not associated with nausea or vomiting. While migraine, usually frontal, okay, usually have one side of the head affected, pulsating, okay, moderate to severe. Migraine can be severe, okay, can persist for up to 48 hours or just be 2 hours. So ask about the duration, very important. It is usually aggravated by physical activity, exercise, noise, or bright lights, okay, and can be related to stress, fatigue, or certain types of food, okay. Certain types of food, especially chocolate, cheese, and coffee, are related to migraine. Family history of migraine present in 70% of cases, especially maternal. So very important to ask about the mother, okay, if she had any form of migraine, okay, that would be beneficial in the history. Okay, so when we classify migraine headache, we have the common migraine, which is more common in childhood, and this is the migraine without aura manifestations, while the classical migraine, which is less common in childhood, is associated with aura. This aura, as we have mentioned, may be in the form of nausea and vomiting, may be in the form of visual or auditory symptoms. Okay, so this aura can be before the headache or during or even up to 1 hour after the onset of headache. The third type of migraine is the complicated migraine, when we have transient focal signs coinciding with the migraine. This usually have a strong family history, and this include, for example, the hemiplegic migraine, when we have a vasospasm, okay, associated with the migraine. This will result in focal signs that is transient, okay, in the form of hemiplegia, okay, that is transient and have a strong family history. Also ophthalmoplegia due to paralysis to the extraocular muscles, and basilar migraine, basilar artery, which carries the blood supply to the occipital lobes of the brain, to brain stem, and to cerebellum. So vasospasm of this artery, okay, can be associated with manifestations like ataxia, for example, or other, or head and the headache, okay, associated with the basilar migraine. What are red flags that would necessitate proper examination and investigations to exclude any sinister or malignant pathology underlying the headache? These include acute onset of headache, severe headache, progressive increase in frequency and duration. It's not static course, but it's progressive, worsened by recumbency, okay, coughing and bending. This is usually related to changes in the intracranial pressure, changes in behavior or academic performance coinciding with the headaches. If headache associated with seizures or vomiting, especially morning projectile vomiting, this is characteristic to increase intracranial pressure. And in children less than 5 years, usually it's not benign. Okay, so these are red flags for a case of headaches that may suggest a malignant underlying pathology. So our workup would simply start with the ENT examination to exclude sinusitis. A sinus radiograph may be ordered, also to exclude otitis media and so on. Any suspicion of abnormalities intracranial, you should order neuroimaging, especially MRI brain would be beneficial. So what is the treatment for primary headaches? Starting with tension headache, explanation about the problem, very, very important to assure patient and assure his parents that this is a common harmless biological fact of life. Okay, we try to adapt with this problem. We usually target to minimize the problem rather than abolishing it, as trying to abolish the problem may be frustrating to the patient. So you should explain to him we target to minimize it. Cognitive behavioral therapy is very important when we teach the patient how to adapt to pain and how to use relaxation techniques to relieve these episodes. The use of simple analgesia also appropriate. Migraine headache. For migraine, also cognitive behavioral therapy is very important, as we have mentioned. Analgesia, but take care no more than 2 days per week to avoid the medication overuse headache. Okay, overuse of analgesia can result in a specific form of headache called medication overuse headache. Prophylactic medications for migraine have certain indications in case of missing school days, or if the episode of headache persists for more than 4 hours, if it's frequent, more than 1 day per week, or if it is severe. For these episodes of headache, we may use prophylactic medications in the form of propranolol, okay, pizotabin, and anti-epileptic medications like valproate and topiramate. Avoidance also of precipitating factors like bright lights, like noise, severe exercise, or any food types associated with migraine should be avoided to reduce the burden of the problem. Okay, so we have entity called idiopathic intracranial hypertension that was called pseudotumor cerebri or benign intracranial hypertension. Okay, so this entity can present to us with headache. Okay, so we have headache associated with signs of increased intracranial pressure. These include diplopia, include blurred vision, or even transient visual loss can occur due to increased the pressure on the optic nerve. Other manifestations of increased intracranial pressure, like projectile early morning vomiting, also can be present. Headaches also can be especially in the early morning. So we suspect the case if we have a headache plus manifestations of increased intracranial tension. Doing a fundus will reveal papilledema. Okay, that will necessitate urgently to do an MRI brain to detect any organic pathology, and normal MRI will be found. Usually the patient is obese. Okay, this condition is related to obesity. Okay, then by completing our workup, a lumbar puncture would be ordered, and finding that the opening CSF pressure during a lumbar puncture is more than 20 centimeter water, this is usually diagnostic for the case. So again, we usually have an obese, usually a female, who has headache and associated with manifestations of increased intracranial pressure. Her fundus show papilledema. She had visual symptoms up to transient impairment of vision. Her MRI is completely normal, but opening CSF pressure is high. So this idiopathic intracranial hypertension that usually has a benign course that resolve after few months, but our main concern is the permanent visual field defect that may result due to optic nerve damage, or even irreversible vision loss can be the result. So we should take this seriously. Okay, we aim at weight loss. Okay, as obesity is a causative or attributing factor. We do repeated lumbar puncture to relieve CSF tension. Acetazolamide, okay, it is carbonic anhydrase inhibitor that reduce CSF production. Okay, and finally surgery. Surgery can be the last resort for optic nerve sheath fenestration in case of optic nerve changes and fear of damage, and the shunting also of CSF can be required. Okay, so talking about head size abnormalities, we have macro and microcephaly, and we have the craniosynostosis. Macrocephaly is defined as head circumference that is more than 2 standard deviation above the mean for age and sex of the child. Okay, if we measured the head circumference by a measure tape and used the gross chart for head circumference and find that the head circumference of our patient is more than 2 standard deviations above the mean, so this is macrocephaly. We have the differential diagnosis for macrocephaly that can be familial macrocephaly when there are no other abnormalities, and we have positive family history with normal imaging, normal examination, and development. So it is familial macrocephaly. Other causes include the hydrocephalus, chronic subdural hematoma, some inborn error of metabolism, okay, especially glutaric aciduria. Okay, remember it when we will discuss it in the chapter of metabolism. So glutaric aciduria characteristically associated with macrocephaly, also mucopolysaccharidosis. We have some overgrowth syndromes that has overgrowth as part of its manifestations. These include the Sotos syndrome and Beckwith-Weidman syndrome. Okay, and this is a picture for Sotos syndrome that has characteristic features also will be discussed in chapter of genetics. When we have tall stature and overweight and macrocephaly with also characteristic facial features in the form of large forehead and pointed chin like that, also the large ears, and usually we have subnormal IQ, and this is a dominant condition, so we may have a family history. This is one of the overgrowth syndrome. Beckwith-Weidman syndrome also associated with obesity, tall stature, and macrocephaly. Other features include the vulnerability to tumor, especially Wilms tumor, also the macroglossia and omphalocele. This will be discussed in details in chapter of genetics. Chronic hemolytic anemia like thalassemia, for example, associated due to extramedullary hematopoiesis and active bone marrow. Neurocutaneous syndromes, including tuberous sclerosis and neurofibromatosis, are associated with macrocephaly. This is the differential diagnosis. Microcephaly, on the other hand, having the head circumference less than 2 standard deviations below mean for age and sex. Okay, microcephaly also can be familial, having no other abnormality, no neurological manifestations, but it can be due to intrauterine infections, including the torch infection or other insult, okay, intrauterine that would affect the brain as placental insufficiency, okay, or somewhat like that. Maternal phenylketonuria is associated with a newborn that can have no phenylketonuria, but he have microcephaly and the mental retardation if the mother is not following the phenylalanine restricted diet. So maternal phenylketonuria associated with microcephaly. Perinatal insult, okay, as hypoxic ischemic encephalopathy. So asphyxia to the brain can result later on to brain atrophy, arrest of brain growth that will result in microcephaly as the main determinant of skull growth, okay, is the brain growth. So if we have arrest in the brain growth as any cause that would result in brain atrophy will result in microcephaly. Encephalopathies in infancy, especially inborn error of metabolism, can result. Neurodegenerative disorders, including the Rett syndrome, this is a very important that will be discussed also in details later. This is the X-linked recessive condition presenting mainly in females in the late infancy. When there is a stoppage or arrest of the brain growth, that will result in acquired microcephaly. So at birth we have normal head circumference, but later on due to arrest of brain growth due to certain genetic mutation that is X-linked recessive in inheritance, presenting in females associated with neurodegenerative changes and loss of the acquired developmental milestones, associated with ataxia, and also associated with acquired microcephaly. Chromosomal abnormalities including Down and other trisomies like Edward and Batou syndromes are associated with microcephaly. So workup would include karyotype to detect chromosomal abnormalities, genetic testing for some syndromes, also metabolic screen, okay, and cranial MRI to detect malformations in the brain. All these can be done in a trial to search for the cause. We have a wide differential diagnosis, so a wide panel of workup can be done. This would depend on the detailed history and examination. Craniosynostosis, where we have premature closure of one or more of cranial sutures resulting in abnormal head size and shape. Okay, so abnormal, if this is the abnormal premature closure of the sagittal suture, for example, will result in scaphocephaly. This is the bilateral lambdoid suture craniosynostosis will result in this plagiocephaly. related to premature closure of coronal suture, trigonocephaly. Okay, we have this trigonal shape of the head like that. So these called craniosynostosis or premature closure of the cranial sutures. This should be differentiated from a benign condition called deformational plagiocephaly, which is related to position. Okay, so supine position mainly, or sleeping of the infant or the newborn on one side can result in abnormal shape or plagiocephaly. That is a benign condition, and repositioning and position techniques can solve the problem. So in a case of craniosynostosis, you should measure the head circumference, you should palpate the fontanelle and the sutures for tense fontanelle and sutures related to increased intracranial pressure due to the premature closure. You should do fundus examination to pick up optic nerve changes associated with increased intracranial pressure due to the premature closure. You should search for any dysmorphic features in the baby, including extra digits, for example, to exclude syndromic nature of the condition, as some cases is related to certain syndrome associated with craniosynostosis. You may do a scaloradiograph, okay, to detect the suture closure. Sometimes these cases need no treatment if there is no increase in intracranial pressure and no abnormality, but surgery may be indicated in cases of increased intracranial pressure or for cosmetic purpose, and usually done before 1 year age. So when we talk about neurological examination, we have a certain sequence. We should not miss one of them. We try to pick up abnormal neurological signs in the patient and collect them, and finally we can easily reach to the neurological abnormality in the patient by doing a proper neurological examination. The neurological examination start with generally examine the consciousness, okay, examine the gait, okay, for abnormalities of gait, and here I ask you to go to the YouTube and watch for abnormal gaits that include the spastic gait, waddling gait, and ataxic gait. This is very important. We hear to the patient and detect if there is a slurred speech or any abnormality in speech coordination. Examine the back for any abnormalities in the spinal cord or skin abnormalities that would suggest also underlying problems. This includes spina bifida, for example. So general examination for consciousness, for the gait, for speech, and for the back, okay, and collect data. Then examine the motor function by separately examining upper and lower limbs, okay. We examine both upper and lower limbs separately for the tone, okay, for power, reflexes. These include mainly deep reflexes like knee and ankle reflexes, and follow it by the superficial reflex of plantar reflex or Babinski. This is very important. And finally, add clonus if you have hyperreflexia. So do clonus to detect the presence of positive clonus, which indicate upper motor neuron lesions. So examine the motor function in both upper and lower limbs by tone, power, reflex, Babinski, and clonus. Then we would examine the sensory function for both superficial sensations and deep sensations. Specifically, deep sensations include the joint and position sense. The joint position, joint sense can be tested in the big toe, okay, by moving it upward and downward, and while the patient is closing his eyes, ask him if he has a sensation of his toe or not. Okay, loss of this joint sense indicates we have posterior colon abnormality in the spinal cord. Also, position sense, if the patient has no sensation of his position while closing his eyes, this indicates he has abnormality in his dorsal column of spinal cord. Okay, and position can be tested by doing the Romberg test. We will mention it now. So sensory function, both superficial and deep sensation. Deep sensations mainly include joint and position sense. Then test coordination for any abnormality that would suggest cerebellar abnormality, and finally do a cranial nerve examination. So general examination, motor function assessment, sensory function assessment, coordination assessment, and finally cranial nerve function assessment.